Smiley, who was my PhD supervisor, and to take a look at the emergency room and some of their policies and procedures. Well, now we're extending her contract to do organization-wide review, to take a look at some of those policies and procedures that impact Indigenous peoples in the hospital, hospital-wide. We have cultural safety training, and we have, that is also just starting to implement too. We now have dollars committed to hire a cultural safety educator who will be coming in. I don't know, I'm working on the job description now, so then we will have somebody coming in shortly for that. EDI physical environment review, that's actually just taking a walk through the hospital and then looking at anything within the hospital that needs to be more culturally appropriate, more able for people who have different abilities, for other equity deserving groups. All of those things will fall under that physical environment review. A lot of that will include security, looking at security policies and procedures, and as well as some of the other people that they have in there helping with that. Now, EDI experience sharing to build understanding and respect. That one is a little bit vague, and we aren't quite ready to start that one yet, but we will see where all these ones lead us into, and then we will take a look at where we're sitting with that. And then lastly, we have Indigenous recruitment and education and retention under that too. So we have, there's a process in the hospital right now, prior to me getting there, for staff to identify as Indigenous. But just as we have the ability to do self-ID for patients, a lot of people are hesitant, and rightfully so, to identify as being Indigenous in some place that's not as safe as it can be for Indigenous people. So this is where we're going to take a look at how much staff we're going to need, how much staff we have existing, what we can do to keep people within the hospital and within, we understand it's a colonial health system. Not everybody wants to work in that setting. I know I didn't, and so I feel that is something that we have to take a look at when we're looking at retention of Indigenous staff members. Okay, so this is the current programming that they have here at the regional now. So they have a number of roles you see listed here. The Indigenous Care Coordinators, known as the ICCs, the IPNs, the Indigenous Patient Navigators and Liaisons, Spiritual Care, that actually just got pulled under my portfolio now too. And then we also have our partnerships with other organizations here in Thunder Bay and the region that include education, discharge planning, wraparound health services. Okay, so these are our lovely ICCs. There's actually one missing from this photo. We have 4 now, and we should have a 5th as well in the next coming months, hopefully. So their role really is to support any inpatients that come into the hospital. So if they've been admitted into the hospital, these are the folks that would be able to help any Indigenous patients that come in. So they play a major role in comforting Indigenous patients that come in. So if they need any help with navigation in that sense, if they need iPads to be able to connect to their home communities back home, if they need discharge planning services, so if they maybe they need to be discharged and they need a mobility device when they get back to their communities, these are the ladies who will help with that. They will connect with non-insured health benefits, and they will ensure that everybody gets what they need back in their home communities. Now, some of them do speak different languages, and they're able to provide interpretive services. They also can link to other different resources here in the city, but also in the region. They are familiar with the different communities and the funding structures, and they're referable in Meditech. So if anybody's in the hospital and you want to be able to see these ICCs, you can ask any person of your care staff and ask to see an Indigenous Care Coordinator. Now, they may be able to help set you up with who your community representative is, because they are pretty general. But if you see Gloria, this is Gloria Bushkikin. So she actually works, she's with one of our partnerships with Anishinaabe Mushkiki. So she actually works for Anishinaabe Mushkiki, but reports to Anishinaabe Mushkiki, physically works in the hospital. So we also have a representative from Grand Council Treaty 3 who works for Grand Council Treaty 3 and works within the hospital similar to Gloria does. She's not in these photos, unfortunately. She's brand new. So this is what, we'll have to get a photo for her. But So their role essentially is just to help with all of this and connect them with certain discharge planners, because if you belong to a community who perhaps is serviced by Deleco Family Health, then they will connect that person to Deleco Family Health in order to help with that discharge. If they happen to be non-status, then they will connect them with like home and community care, and they will ensure that all those connections are made. They definitely need more because we see the population. When we take a look at the population of Thunder Bay, particularly from even like our health counts, that's showing that it's significantly higher than what Stats Canada is reporting, then we need more of these folks here. But that's part of the role too. We want to build that up and actually leverage some of those numbers to say we need more from the Ministry of Health. Okay. IPNs. Okay, so the IPNs, their main role is to do almost essentially what the ICCs do, but they do it for outpatient clinics. So you will see these four. They work in, we don't have a picture of Mona. She's actually in the emergency department, works with Lisa. Want to get a picture of Mona. But, and then we have Angela, complex diabetes care, Jeannie in cancer care, and then we have, names just want to write on my head, Susan and Lorraine in Reno. Now, yeah, so like I said, they will help navigate certain departments that they're in. So if a patient comes in and they're going to Reno, for example, then these people are available to help them navigate in the renal department. Now, if that patient comes in and they are admitted, right, if they're here to see a renal, but then they get admitted, these IPNs will follow them into inpatient, but then they will also connect them to those Indigenous care coordinators who work with the inpatients. Let's see what's available. So these are the people that you would also see if you needed things like cafeteria vouchers, bus tickets, taxis, all those kind of things. They will help with all of those services available. Spiritual care. Okay, so this is new to me in my portfolio. Initially, I just had the ICCs, and actually the IPNs aren't even in my portfolio right now. We're looking at some sort of matrix reporting because they currently report to their departments. But with spiritual care, we have a number of spaces available. Last year, they were able to get the teepee space and the spirit garden. So the teepee is just sort of in the back of the hospital, and it needs to be put up again whenever it stops snowing. and then the spirit garden too, as well. That'll have to be taken care of this year too, and that's sort of just outside of pediatrics, available for use and rehab in that area. Now, the multi-faith room. So the multi-faith room is actually the only place right now that's equipped for smudging. So if we wanted to do something, I think St. Joe's is available. Like they went through a number of testing, I think, to be able to take a look to see if it could be done in different rooms. And that's probably something we will look at within our physical environment review when we do that walkthrough. Now, spiritual care will also provide smudging and bedside ceremonies with that, and traditional knowledge and practices, televisitation. So if they need to set up and call through the iPads that the ICCs will link to, they can do that. And then again, a link to external resources. The way it sits now is that there's a spiritual care provider for multi-faith, and then there's an Indigenous spiritual care provider. That role is sitting currently empty, so that's one of our first tasks to do, is now that we've taken on spiritual care, is to hire somebody within that role. And then also it will be their job to help get more of those casuals that we have within spiritual care, because we have a number of casuals for the different faiths, and so we need some casuals too for some Indigenous spiritual care. Okay, these are a number of the partnerships that I was talking about earlier. So we work very closely with St. Joseph's Care Group because they're part of the hospital umbrella. Okay, I wasn't sure if that slide was there, but it is, so I'll leave that to the next one. We have partnerships, like I was saying, with Anishinaabe Mishkiki and Grand Council Treaty 3 as part of those ICCs that come into the hospital to work. Deleco Family Health will have their discharge planners that are also present there too. SLIFNA is also looking at having their ITFs available to people here at the hospital. And then we work with Watauga Education and Care Center, very specifically with Lisa Beck and her team. And then we just implemented Wake the Giant training in partnership with Dennis Franklin Cromartie, where this is the first time that Indigenous specific training has been made mandatory. They had the respect training, but this one is made mandatory for all staff, all medical staff, as well as volunteers coming in. So this is a short 20-minute sort of introduction to what is needed when a student from a remote community, for example, would come into the hospital. So that's very specific, it's very localized, and it's very specific to students. Okay, and like I was saying, how we partner very closely with St. Joe's, we actually have a joint committee with them now. So this joint committee is called the Indigenous Health Education Committee. And initially it was their committee, but then when I came on, they asked if we wanted to join up with them. So what it currently looks like now is that we have 50% Indigenous and then 50% allies coming to help with that. What I'm discovering, being in the hospital setting, is that allies are important, particularly when you're looking with like medical staff that aren't, I don't know how to say this in a PC way, but I think you understand that they are hesitant to work with certain people, I think, because of, I don't know, hierarchy, I guess is a way to say that. Now, so that's how they've structured this committee, and we're providing monthly education based on like things that they've already focused on, which included residential schools, Indian hospitals, the Indian Act, United Nations declarations of Indigenous people's rights, treaties on Indigenous rights, Indigenous teachings and practices. And then they also created a document that helps the allies on this committee to help guide their code of conduct. Their guiding principles essentially is just for learning their truth. That's what they say here, is that they're learning their truth. This is right here, this is just the logo for the St. Joe's Indigenous Relations team. Now, this is just starting up here. So that's why we're bringing in this cultural safety educator to help implement some of this training that's coming through part of this IHEC committee. I would love to do it because I really like teaching and that sort of thing and working with students, but that's not my role anymore. Okay. Future plans. Okay, like I was saying, we're bringing in this cultural safety educator. We're bringing in that 5th ICC. We're going to further promote that Wake the Giant because it is mandatory. They do have to take it. Wake the Giant is pretty creative with some of the things that they're going to be bringing in, I think, to the hospital to help promote that too. We're going to increase the cultural safety training resources, and then we have our events that will come on, and that'll be part of that cultural safety educator role as well too. And then we're further seeking more partnerships and collaborations from anybody who would want to help us out with the work that we're doing here. Okay, and I think this is Lisa.
I don't know about you, but that's a lot of work. What I'm going to share with you is some of the work, and as Miranda has indicated, partnerships are so important. We need to hear not only from youth, but from our partners of what is needed. How can we make care better at the hospital? So for the last several years, I've been working with First Nations Indigenous Partners Committee, and we've been actually working on quite a bit of material and updating documents so that we're preparing our youth for coming to the hospital. What we've completed so far is we've completed a student orientation resources. So these are one-page handouts that can be used with families, with educators, with organizations that go over what to expect when you're coming to the emergency department. What do you need to bring, and hopefully educate on making this a less scary environment. We've created some tools for nurses, and in the emergency department, as an example, there's about 200 nurses. And what helps nurses do things consistently is by having forms and algorithms and documents that when someone comes in, they can refer to this document and work through scenarios. And sometimes there are scenarios where youths arrive without a parent or guardian. And this particular document, discharge form, will help these nurses who may have never encountered this before of how to work through that. What are some of the options? Who do I call? And really reiterate, it's so important to get that consent from the youth so that we can connect with family, we can connect with educational facilities. We've updated our patient transportation policy. It used to be quite rigid in that we don't hand out bus passes and taxi slips and things like that. We've updated that and made it more inclusive, up to age 22, and those can be available to all of our youth. We actually have bi-monthly or bi-weekly and monthly meetings with Matawa, and the emergency department manager and coordinator meet on a regular basis and talk about particular cases. So if there was a particular case, the coordinators from those educational facilities can call our coordinator or our manager and say, you've got to look into a particular case, let's work it through. And we really want to hear about those sooner than later to make those improvements. We've actually had many documents written, one of which is quite innovative. What we're calling that is a student consent pilot. And we've been working with the educational facilities. Matawa has expressed interest in being one of the first to go with this pilot. But what we're envisioning is that upon intake to an educational facility, the facility will get consent from the youth to say, if you end up at the hospital, we want to have that on your medical record so that we know that there's a connection between you and your educational facility. And once that consent is obtained, it doesn't release all the health information, but what it allows the nurse to do is recognize that this individual is associated with that particular educational facility. It'll come up, you know, such and such is registered at Matawa as an example. So then the conversation is really about engaging in that dialogue and indicating and really working with that youth to say, we know you're a student, we'd really like to be able to call Matawa. We know that there's support there as an example. So once that consent is obtained, it will then go into our medical records. It will be available for nurses and staff to know the connection so that we can bring in the extra support that's needed while they're in the emerge to be able to facilitate a safe discharge. Discharging youth, again, this can be a tricky situation, recognizing that youth do have to provide a degree of consent to allow us to call somebody. We do have forms that help guide that situation because there are situations where they're unable to consent, they're unconscious, they're not, you know, they're confused, they're agitated, whatever. So this form helps the nurse troubleshoot through a scenario like that. And also, again, provides options. So on that particular form, there are options, student safety line, different options. Have you considered giving taxi slips? Who are they being discharged to? That really helps work through this tricky situation. I've already mentioned that we've updated our protocols to more easily give out those taxi vouchers, those bus passes, recognizing that transportation is a big concern for many, and many people do not have transportation. And again, we work with various educational facilities, partnerships, as Miranda has indicated, and we really are right now just working with a proposal with a group to look at not only youth sobering site, but adult sobering site. So more to come in the future on that. So what's in the works? Well, besides what Miranda has said, that's a lot in the works. We have advocated, and we do recognize that having one Indigenous patient navigator in the emerge Monday to Friday, that's not enough. You know, people come in 24 hours a day. So we're really advocating for additional funding to expand that into the evening, into the weekends. So we have put in a ministry request for funding, demonstrating the need, looking for expanded coverage of our Indigenous patient navigator. We don't have a dedicated social worker. We'd like to have that on staff. We do have access to one social worker that works between the intensive care unit and the emerge, but again, they can only be in one place at a time. So we've requested to the ministry, we need a dedicated social worker, we need peer support. And we also have put in that we need an additional psychologist so that referrals can be sent in and then patients can be seen in a more quicker fashion. As Miranda had indicated, Dr. Janet Smiley had started to work with us, and she worked with us for about 6 months looking at two main policies in the hospital: workplace violence and the emergency department standard operating procedures. And what we learned from Janet is that our policies needed to have more proactive approaches, more examples of how to de-escalate situations, and bringing in that Indigenous cultural safety. So we've embedded some of those key learnings and are working by an updated policy. We've also recently renovated our room that's in the ambulance bay, and sometimes we get patients that come in with police or ambulance and they're very agitated. So what we've just constructed and renovated is a space, a safe space, a quiet space where nurses and doctors can be in a room. We're envisioning it as being a very short period of time, so less than an hour, but to settle somebody down before we end up bringing them through the main department. So that de-escalation room renovations was just completed, and now we're just working on the protocols of who's going to go in there, how do we, who's going to be assigned, those operational details. We've actually put in more safety enhancements for access control, meaning doors, automatic doors. Nurses and security have the ability to lock those in and out. Some additional cameras, making it safer for everybody. You may have heard in the news or otherwise that we do have police in our department. We've had them in there since July, and they are there from 5 p.m. till 5 a.m. and they roam in the department, and they have been very, very helpful. We recognize that sometimes there are people that are triggered by the presence of security or police, and we've worked in protocols to address that situation as well. So the police are there, and they will be there probably for the next year. Go ahead.
I just wanted to ask about the security. Do they get the training?
Yes. Yeah, so our security at the hospital is a third-party vendor. It is through Garda Security Services, and they do come with training, but we also allow the security guards to take additional training, such as, crisis intervention, how to work with individuals that are unwell, etc. So we provide them at the hospital additional training. Yeah, you're welcome.
And that's too, that's what we'd like to specifically be looking at.
And really good question, because it really does take a special person that takes training and dealing with sick, agitated people that are not in their best. So you need that ability to interact with them in that respectful way. Did you have a question as well?
Yeah, you use that term cultural safety. What do you mean in respect to that? Putting those two words together. Yeah, so sorry.
Thank you. That's not up to us to define, right? Like, because as a hospital, we can't really define it as what's safe. We need the community to tell us what's safe, right? So we need the feedback from our partners and the feedback from the patients to tell us whether or not this is, frankly, a shitty place to be. We know that it is, right? So we keep hearing that. We want to make that better. So people do feel safe, right? And it's related, I guess the way that the term is, it's sort of, it's an academic term, I think, where they link what your culture is, and that the place that you're going to is going to acknowledge that your culture and where you come from, what your background is, affects your health. So that's what when they use this term cultural safety, that's what it's sort of referring to, is that and you feel safe and you don't feel unsafe because of who you are as a person, because of what your culture is, because of what your background is, kind of thing. So that's what it's trying to address, I think, in that sense too. But we don't define it. or I'm sorry, we can't say that we're safe. Like you can't declare I'm a culturally safe place, right? You can't do that. We have to get the feedback from the community to say that we feel better coming to this place.
So what is your process for getting that?
So right now, they've started with a self-ID kind of process. Now, when you get there, you can pretty much, they're supposed to ask you when you're admitting to ask you if you want to identify as an Indigenous person. I'm actually surprised with the numbers at this point. The numbers are pretty high because I think I haven't identified and I work there kind of thing, right? So I'm not entirely sold, I think, on the idea, but people have been identifying to say, because I think the feedback we do get sometimes is that what happens if I identify and I receive worse care? And some people do report saying that they do have worse care after they've identified. So that's something that we have to take a look at in the self-ID process. Now, the other thing that they do, what they're looking to re-implement is that, I guess before they were doing patient experience surveys, and they've changed vendors. So somebody would do it before, and now they're looking at going at a company called Qualtrics. So with this survey, they're going to ask patients about what their experience was in the hospital. So they have the opportunity to talk about, like, rate whether, how it was, and they can also talk about, enter in anything very specifically if they had an experience that was negative. And then currently what people have been using is it's called the compliments and concerns database. And you can either get the paper in the hospital and fill it out and put it in the boxes, or you can go specifically to the website and you can enter in what you're concerned about. And then what that does is that it flags it very specifically with the department that you're in and what you may have had a concern about. It will send to that department and they have the opportunity to respond, but then because now I'm in the role, it also flags me. So then I get to see what happened in these certain cases, and then we address it from a high level and take a look at what we can do very specifically to not ensure that that doesn't happen again, kind of thing.
This is really tricky because how do you guess power balances when we don't have that?
So that's what we have to require that to figure out how we're going to do this with the system. Well, but we still have to get presented surgery, make sure we get the surgery, still be mistreated.
And you're always on the defensive. Because you're worried about it.
Yeah, and that's the thing, and that's where some of the training comes in, like for our own staff. Is we have something that's communicated, right? So we can be thinking about directing that. Saying, like, talking to staff. Right. This is the reason why people need to come. This is the reason why people not distressed. This is the reason why this is why people react in ways that correct. Well, you just that's the main thing.
That's what we're getting. You know, it's not a lot of happy.
Yeah,
And it was very, because we have a circle. Yeah, so it's really very. So people are able to listen, share, and so yeah.
and to, as part of that cultural safety educator role, they're going to be looking at nurses and short scholarship fees because they don't get paid. So we have to sort of getting them paid or getting shifts covered off or some sort of thing. Those people get.
And I think it's really important, and that's, the real-time situations that occur, that also helps us improve things right away. So again, you know, in various groups, we really rely on the input and the storytelling and the feedback. But I would prefer if there's an incident that we're dealing with it right there and then, because we don't want 6 months to go by and have the same thing happen to others. So we do really encourage reporting and connecting. And if it isn't the individual, they're not comfortable reporting that, again, they can do it you know, through the voice or through the Indigenous patient navigators, that type of thing. But it is important that we catch it early, we make changes. One of those changes that we are doing is looking at the triage desk. When you come in, it's an open desk, everybody hears what you're there for. We're going to be endeavoring in a $3 million renovation through the 50-50 draw. You may have heard that on the news as well. And this triage station is going to be built into 3 or 4 separate intake booths where people can come in and talk about what's going on in a more private setting. So that will be coming. So I think that is it for our presentation. Yes, questions? A couple of things, and then I'll hand it over to Miranda. So the question is around, if you don't know all these great services are there, how do you know to ask for them? So we really rely on our staff to recognize that if there's somebody that, like the Indigenous patient navigator is there for everybody. And what we try and do is say, go and take a, you know, that Indigenous patient navigator who works in the emergency department will go around through that department, is very visible. A family member can say, hey, come over and talk to them. Or as a nurse or as a director, I can say, have you visited this person? It looks like maybe they could use somebody to talk to, or, you know, there's some questions about this or that. So it can be in any way. And again, we want our staff to be able to utilize these individuals. The difficulty is there's only one individual. And so if that one individual is with a particular patient, then there may be 3 people in need. So then we'd have to look at the other, you know, Indigenous care coordinators, are they available? So I guess the need outstretches the amount of resources that we have. That's kind of what it comes down to, because everybody could use some additional support while they're there for the most part, but we've only got one person. So we try and recognize who is priority. Being very visible is important. So our Indigenous patient navigator is circulating through the department and will be given direction of who is in need. And she can also source out, or you can even say, hey, do you have an Indigenous patient navigator? I heard you do. Can we talk to that individual? So it's a little bit of all sources of how do you get in contact, but we want our nurses and staff to be able to say, we've got this resource, can we invite them to your bedside?
I don't know if you had mentioned, but are the educators, are they there?
No, not currently. There are social workers in other parts of the hospital after that hour, but yeah, and they would have to bring in somebody, but from the ED, it's like 8 to 4.
8 to 4 for our Indigenous patient navigator.
Yeah, so
Monday
that's
to Friday only.
And yeah, and that's why we're advocating for additional resources from the ministry so that we can extend that. And yeah, because we recognize that 8 to 4, most people are not there from 8 to 4. That's why they're an emergency. But to like answer that question too about visibility is that even me coming into December, that was my first role. We just actually hired a manager, and then right now we're working on role distinction, because what we're recognizing is that the ICCs, the IPNs, the discharge planners, the social workers, they're all doing a similar job kind of thing, right? So that's creating confusion actually within the hospital. So oftentimes people will ask for an IPN or an ICC, and then staff will be like, oh yeah, that's the IPN, and they will send the IPN. So like we are really working on a process right now to make that role distinction. get that messaging out to staff internally, as well as if there's a number of things, like things have to be corrected in Meditech, because I think it says IPN under there and it's an ICC. So yeah, it's just looking at all of these little things that I think could create confusion and fixing some of that. And then the ICCs are actually working on promotional videos right now. So they are working with, I'm not sure what the company is, but with Grand Council Treaty 3 to get some of their services more broadly advertised out there. And now the website is actually up to date too. When we came in, and I first came in, even I was confused, so like, because only the IPNs are on the website. So now the ICCs are there, the IPNs are there, they're all separate, and then we could, make it a little bit more well-known about what's available. And more specifically, like, I think I had a slide too with our contact information and the manager's contact information. And so generally people will either reach out to me directly or to Paula, our manager, as well as Annette. And then we have a generalized email for the ICCs. So with that, there'll be days where I'll just be sitting in my office and somebody will say, we need an IPN this place, right? So then I just text around and find out where they are, and then we will get them what would they need at that point. But again, like I said, 8 to 4, so we really have to beef up funding structures, more coverage.
And we're just wondering about the social work contribution, but the social worker that we're gonna try and get.
Yes, eventually, yeah. So that's coming in as well.
Thank you, I think we're perfect.
Thank you very much.
Thank you. Any questions?
I just wanted to say some closing remarks. Thank you, ladies, both, and on behalf of NAN, we have a little gift over here for you guys today for presenting, and
Thank you. This one's for you. Thanks very much.
absolutely. And there's one from Miranda as well.
Yeah.
There you go. And anybody in the room, if you guys have any questions or anything for the ladies, I mean, their email addresses can be made available to you. And I can even be that point of contact as well. And I'm sure if you have any further questions, I don't know how long you ladies will be here this afternoon, but they'll be more than willing to answer any of those. Again, thank you guys.
Thank you.
Everybody.